Hi, today we are going to discuss about ventricular septal defect. This is the most common congenital cardiac anomaly where there is going to be left to right shunt. So with this said, we will get into the topic. So to know about ventricular septal defect, you first need to know how your interventricular septum develops. So in the last class, we discussed about how your interatrial septum develops. So now we are not going to get into that topic. We will just move on to the interventricular septum. So interventricular septum, basically it starts from below and it develops above towards endocardial cushion. So we discussed that there is going to be endocardial cushion, so towards which your interatrial septum also develops to join and your interventricular septum also develops to join. So this part is your endocardial cushion. So this is your interventricular septum. Now in your interventricular septum, you have got two important components. One component is going to be muscular and the second one is called as the membranous. So you have two important components. So one is the muscular and second one is membranous. So this is in general about your interventricular septum. So what you see at the below is your muscular component and what you see above is your membranous component. Now when we talk about the detailings of this ventricular septum, so the defect can be of four important types. The first one is called as the muscular ventricular septal defect. So where you can see it can be a multiple trabeculae or it can be a single defect. So when it appears like a multiple trabeculae, then this is called as the Swiss cheese appearance. So this is called as the Swiss cheese appearance. So this is a defect seen in the muscular part of your ventricular septum. And you can have a septal defect just below your aortic or your pulmonary valve, which is called as your outlet ventricular septal defect or your infundibular ventricular septal defect. So this is present just below your pulmonary or your aortic valve. Now moving on to the third one, which is the most common of the entire ventricular septal defects. Almost 80% of ventricular septal defect is going to be membranous type. So 80% is going to be membranous type. So what is the main function of this perimembranous part? It mainly prevents the communication between your right atrium and your left ventricle. So when this defect is going to be there, there is going to be some abnormal communication between your left ventricle and your right atrium. So therefore this perimembranous is the most common type of your ventricular septal defect, which is going to be 80% of ventricular septal defect. So what is the last uncommon type? So the fourth type is going to be called as inlet or atrioventricular canal ventricular septal defect, which means it is just present below your tricuspid or your mitral valves. So this is called as your inlet or atrioventricular canal ventricular septal defect. So there's almost 8% people of ventricular septal defect can have this type of a defect. But 80% will be membranous. The next common type will be your muscular, which is around 15 to 20%. So the other types, that is your outlet or inlet, is going to be rare type, 8% to 6%. So these are the types of ventricular septal defect. So what causes this ventricular septal defect? It can be either congenital or it can be acquired. So when we talk about congenital causes, it can either occur as an isolated congenital cardiac anomaly. So you can just have ventricular septal defect. Or it is present in association with other congenital cardiac anomalies like your atrial septal defect, or it can be patent ductus arteriosus, or it can be with pulmonary stenosis. So it can be present with any other congenital cardiac anomaly, or it is present in the tetralogy of Fallot, so which you all know. Sometimes genetic factors also contribute to. So where we have discussed about a TBX5 mutation in atrial septal defect, which is called as Holt-Oram syndrome. So this can be with atrial and the ventricular septal defects. And whenever the mother is exposed to rubella infection during pregnancy, or is exposed to alcohol, or there have been phenylketonuria, or there have been exposure to drugs like ibuprofen, cocaine, or maternal diabetes, all these are risk factors for the congenital VSD development. Now next one is acquired. So when can you have acquired? So acquired, most common cause of acquired ventricular septal defect is post-myocardial infarction. So post-myocardial infarction, so there can be ventricular septal defect developed. Now moving on to clinical features. Now whether the person is symptomatic or asymptomatic is dependent on the size of the ventricular septal defect. So basically, how do you categorize the size of ventricular septal defect? So for that you need to take the aortic annulus diameter. So you take the diameter of your aortic annulus and you compare the size of the defect. So if the defect is going to be less than 25% of the aortic annulus diameter, it is called as small ventricular septal defect. If it is going to be between 25 to 75% of the aortic annulus diameter, it is going to be called as medium ventricular septal defect. And whenever it is going to be more than 75%, when the defect is going to be more than 75% of this diameter size, it is going to be termed as a large ventricular septal defect. So whenever we talk about the small ventricular septal defect, usually these people are asymptomatic. So only your medium to large ventricular septal defect people will develop symptoms. So what is the basic pathophysiology behind the symptoms? So when we draw a schematic diagram showing your heart with 4 chambers, this is your right atrium, this is your left atrium, this is your left ventricle, this is your right ventricle. So when you're going to discuss, from here you're going to have the pulmonary artery which is going to go to the lungs and all that. So whenever there is going to be a ventricular septal defect, whenever the septum is damaged, so what happens is there is shunting of blood from left ventricle to right ventricle. Because the pressure in the left ventricle is a little higher while compared with that of the right ventricular pressure. So therefore blood shunts from left side to right side. So when blood moves from left to right, what happens to the volume of blood in the right ventricle? It is going to increase. When the volume in the right ventricle is going to increase, obviously volume in the pulmonary artery is going to increase. And we have discussed multiple times in the pathogenesis of cor pulmonar or in the pathogenesis of your atrial septal defect that whenever there is going to be increase in volume in your pulmonary artery, whenever there is volume load, the pulmonary artery is going to undergo certain changes to develop pulmonary artery hypertension. So it can be vasoconstriction, it can be because of the smooth muscle proliferation, and third, it can be because of your obliterative effects of your pulmonary artery. So all these three together can cause pulmonary artery hypertension. So therefore the pressure in your pulmonary artery is going to increase. Now when pressure in your pulmonary artery increases, this reflects in your right ventricle. So therefore the pressure in the right ventricle is also going to increase. Now when this is high, then this will pump or shunt the blood from right ventricle to left ventricle. So there will be right to left shunt which develops, which is what we call it as Eisenmenger syndrome. So therefore whenever the person develops pulmonary artery hypertension, later on the person can develop right to left shunt, which is called reversal of shunt. So therefore the person can have Eisenmenger syndrome. Now what is the problem with Eisenmenger syndrome? So because the blood is shunted from the right side to left side, so what happens to the oxygen content in the blood? This is going to come down. So when the oxygen content is going to come down because of hypoxia, there can be features like clubbing, which can be seen in the person. There can be cyanosis, bluish discoloration of the skin or mucous membrane. There can be syncope because of reduced cerebral perfusion, and there can be polycythemia. Now, why there is polycythemia? You know, whenever there is going to be hypoxia, this causes your erythropoietin to increase, and when erythropoietin increases, your RBC is going to increase. So therefore, people with Eisenmenger syndrome, you can have polycythemia. Now, with respect to ventricular septal defect, apart from discussion of Eisenmenger syndrome, development of pulmonary artery hypertension and all that, these people are also more prone to infective endocarditis. So this is very important, which you have to remember. So people with ventricular septal defect can also be prone to develop infective endocarditis. Why that is so? Because whenever your blood is going to move from your left ventricle to right ventricle, it is going to cause some damage to the ventricular wall, and therefore this will make it a seat for your bacteria to grow. So therefore, these people are more prone to develop infective endocarditis. And they are also prone to develop thrombus and the embolus. So therefore, this is also a problem in people with ventricular septal defect. Now, when we discuss about the clinical examination findings, so what can you notice in people with ventricular septal defect? So normally people with small ventricular septal defect, I told you they are going to be asymptomatic, but for these people the murmurs will be very loud. So the murmurs will be very loud. So they will have the loud murmurs, which is very important. So this is called as Malady de Roger syndrome. So what is Malady de Roger syndrome? So where you have loud murmurs in small ventricular septal defect is called as Malady de Roger syndrome. Now moving on to medium to large ventricular septal defect, I told you these are the people who are going to develop pulmonary artery hypertension and Eisenmenger syndrome later on. Almost 15% people develop Eisenmenger syndrome, or they develop the congestive cardiac failure. So these are the people who are going to come to you with symptoms. So in these people, when you do clinical examination, what are the findings you can look for? So you can find parasternal heave, because yes, there is going to be the right ventricular hypertrophy due to increase in the volume and the pressure load. And if left ventricle is also going to undergo hypertrophy dilation, then for these people you can also see displaced apex beat. So they can also have displaced apex beat if there is going to be left ventricular hypertrophy or dilation. And when you talk about murmur, you can hear a pansystolic murmur. So you can hear a pansystolic murmur, which is most probably heard in the left lower sternal border. And when there is going to be an outlet VSD, there can be diastolic decrescendo murmur. So you can have diastolic decrescendo murmur. So this can be heard whenever your aortic valve is going to be involved. So what are the investigations you can do in these people? So yes, the single most best investigation is going to be echocardiography. So this is going to tell you about the size of your VSD, your location of your ventricular septal defect, the status of your valves, whether there is going to be any other defects associated, what is your chamber size, function, everything can be found with echocardiography. The next, MRI and CT. Yes, if you're going to have a complex anomaly, then this can be found using your MRI and CT scan. So ECG will tell you if there is going to be right ventricular hypertrophy, right bundle branch block, or there is going to be right axis deviation. All this can be found with ECG. Your chest X-ray will again tell you the chamber size, and also your pulmonary vessel diameter can be found with chest X-ray. Your right heart catheterization will tell you the pulmonary arterial pressure. So how do you treat these people? So usually small VSD people, they are asymptomatic, so you don't have to treat them per se. But whenever person is going to develop symptoms, whenever a person has got medium to large VSD, yes, you have to treat them. Small VSD, usually 90% they close spontaneously. 90% of VSD they close spontaneously. But whichever is not closed, you have to treat it surgically by using percutaneous VSD closure. And if suppose the symptoms are going to be too bad, if the person has developed too bad complications, then the main mode of treatment is going to be your heart-lung transplantation. So it is going to be heart-lung transplantation. Now apart from that, because the person has got pulmonary artery hypertension, you need to give the pulmonary artery vasodilators also, so which can give some amount of relief to these people. And if they have developed infective endocarditis, yes, you have to treat them with antibiotics and all the supportive medications. So surgical closure is mainly with percutaneous VSD closure, so which is going to be for people who starts to develop symptoms. So now this completes your ventricular septal defect. So ventricular septal defect in nutshell, ventricular septal defect is the most common congenital cardiac anomaly where you have left to right shunt. And second, the pathogenesis is mainly in the development of pulmonary artery hypertension, and later on they can develop Eisenmenger syndrome. So how do you treat these people? It is with percutaneous VSD closure. So this completes the discussion of ventricular septal defect.